Hello, and welcome to this lecture on postpartum hemorrhage. We're going to first start with the incidence and definitions. It does continue to be a leading cause of maternal morbidity and mortality worldwide. It's defined as a blood loss of 500 mLs or more for a vaginal birth and 1,000 mLs or more for a cesarean delivery. It's important to understand that we need to quantify blood loss, meaning that we need to measure dry pads versus saturated pads to come up with a quantity, rather than estimating blood loss. It does occur in 2.9% of all births and has increased by 27.5% despite no changes in risk factors of women. And we're going to discuss risk factors in the upcoming slides. Blood loss is often underestimated by as much as 50%. That's why we don't want to use an estimate. It can lead to hypovolemic shock, and this is really the end result of a massive hemorrhage. It can be an early or late postpartum hemorrhage. Early is defined within 24 hours, and late is 24 hours to 6 weeks postpartum. Although I have seen late postpartum hemorrhage occur even later than that, 8 to 12 weeks. These patients often present to the emergency department. Early postpartum hemorrhage, the causes are upper and lower genital tract lacerations or urinary tract lacerations, retained placental fragments. This usually leads to uterine atony, which we're going to discuss in detail, invasive placenta, uterine rupture, uterine inversion, and coagulation disorders. Late postpartum hemorrhage causes are infection, retained placental fragments, placental site subinvolution, coagulation disorders, and they may require a D&C, also known as a dilation and curettage. This is where we go in, put the patient under general anesthesia, and scrape out the uterus with a curette. Now, infection is really a main cause, and it kind of goes hand in hand with the retained placental fragments. So subinvolution just means the uterus is not returning to its pre-pregnant size as we would expect it to. It should become a pelvic organ after 2 weeks of delivery. We should not be able to palpate the uterus. So if we're able to palpate it, we know that the uterus is going through subinvolution. Etiology and risk factors include uterine atony. A few minutes ago, I mentioned uterine atony, and you have to think about this as an atonic uterus. The uterus is not able to contract as it should. You need to know this for exams, that it is the number one reason. So it can be caused by a multitude of things, and most of these are going to include things like anything that might make the uterus larger than expected, or anything that may tire the uterus. So these are things like high parity, having 5 or 6 more babies, polyhydramnios or excessive amniotic fluid, a large baby, obesity, multiple gestation like twins and triplets. All these things cause overdistension of the uterus. Think of it as a balloon that you overfill past capacity, where it's almost going to pop. When you let the air out of that balloon, it's very, very stretched out. Think of the uterus as doing the same thing. And keep in mind it is a muscle and it needs to contract down in order to prevent bleeding. Other causes include magnesium sulfate. Again, this is a medication we use with preeclampsia and preterm labor. Magnesium sulfate is a muscle relaxant. It's going to relax every muscle in the body, including the uterus. Rapid or prolonged labor, chorioamnionitis, which is an infection, and the use of oxytocin to induce or augment labor. So all of these things are going to tire the uterus. We often give oxytocin after delivery. We're going to talk about the treatments for bleeding, but we're giving the woman oxytocin as a first-line agent to prevent hemorrhage. But if we're using massive amounts of oxytocin during labor, she's not going to respond to it after delivery because the receptors are full. Previous history of postpartum hemorrhage. This is your first clue that the patient could be at risk for postpartum hemorrhage. So when you know a patient has a history, there are things we can do to help prevent it from occurring again. Precipitous birth. This is a very rapid delivery. Most of these lead to lacerations. Shoulder dystocia. The uterus is still contracting and working hard to try to deliver the baby, but when the shoulder's stuck under the pubic bone, this isn't really possible, and the uterus will abnormally contract, and this again will tire the uterus, setting her up for hemorrhage after delivery. A full bladder after birth. Now think about this when we have patients that have epidurals. We take the catheter out when the patient starts pushing. So if she's had her catheter out and she's pushed for 2 to 3 hours and we haven't emptied the bladder, she's going to have a full bladder. Plus we're giving her fluids and we're making her bladder full. So we have to think about those things. Maybe she didn't void for a couple of hours before she delivered if she did not have an epidural. So we need to empty the bladder as part of our interventions, which we're going to talk about. Retain placental products. The placenta should deliver within 30 minutes of delivery. Okay, most placentas will deliver within 10 minutes. Up to 30 minutes is normal. If it's exceeding that, it's kind of a prolonged amount of time, and we worry about retained placental product or one of the placental abnormal adherence disorders, which we're going to cover. So as I said a moment ago, abnormal placental adherence. So there's 3 types: accreta, incurreta, and percreta. We're going to discuss each of these individually. The placenta should be inspected to be sure that all the pieces are there. Otherwise, suspect retained placental products. Now, a placenta is fairly easy to inspect. When it delivers, it comes out in one piece with the membranes attached. So you want to look at it. It should be nice and round and uniform. And when you hold it out, if you're looking at the side that's attaching to the uterus, there's little chunks. They're called cotyledons. And you can see if there's a cotyledon missing. So if it's not looking uniform, all the pieces are there, just like a puzzle, then you should suspect retained placental product. Plus, manual removal of the placenta fragments may be required. So if there is a piece up there, the patient's bleeding, we have to go up there and remove it because it's an irritant and it's just going to cause the patient to bleed. Placental accreta significantly increased due to the rise in cesarean deliveries. We should always keep in mind, especially when we're doing education with patients, that cesarean deliveries are not benign, okay, especially when they're having 3 or 4 or 5 cesareans. Okay, every time we cut into that uterus, it damages the uterine wall, and this sets the patient up for these kinds of problems. Genital tract lacerations, so cervix, vagina, perineum, or labia. Perineal lacerations are the most common, and that's good news, even though it's a laceration, because we can see it and be able to easily repair it and see where the bleeding is coming from. Hematomas are a collection of blood in connective tissue, and a lot of these we don't always see. They may have a labial hematoma, which is very easy to spot, but they could have a hematoma up inside the vaginal wall that we can't see. And these patients are prone to hemorrhage. So we have to pay attention to the patient and monitor them hemodynamically because they can deteriorate rapidly if they're hemorrhaging internally. Undiagnosed coagulopathies like von Willebrand's disease. Most women, when they start menstruating, know they have this disorder. Okay, so let's talk about abnormal placental adherence. Okay, accreta. This is an abnormally invasive placentae chorionic villi growth that causes the placenta to adhere to the uterine lining instead of the decidual layer. Okay, so we want it to adhere to the uterus, but the innermost layer is a decidua. And this is more like a membrane that covers the endometrium. So this is where we want the placenta to attach. It allows for easy removal of the placenta. This is why most placentas deliver on their own without any need for removal. They peel away clean without any issues. Now, if the placenta adheres to the endometrial wall itself, that's what we call an accreta. And that decidual layer is absent. And that can be caused by uterine surgeries and multiple cesarean deliveries. It's not always the case 100% of the time. We have seen these in first-time moms who have placenta previa. An increta is a choriotic villi involving the myometrium of the uterus. So again, this is the middle layer, the muscular layer of the uterus. So it has a greater degree of invasion. It goes deeper. And then the severity really depends on how much of the placenta is adhering. Is it just a piece of placenta or the whole entire placenta? So if it's just a piece of placenta, we refer to that as a focal, okay, a focal increta, accreta. Per accreta, a choriotic villi growth through the myometrium and serosa and may attach to other organs or tissues like the bowel or bladder, or even in the peritoneum. So this is really severe. Okay, the placenta is actually growing through the entire uterine wall and out into other organs. The diagnosis of placenta previa and previous cesarean birth requires careful planning and a repeat cesarean delivery. Okay, so a note with placenta previas, we assume they're an accreta until proven otherwise. Okay, meaning we automatically prepare and set up the patient with a known placenta previa as though we're going to have this complication. So risk for abnormal placental adherence, so previous cesarean, as I said a moment ago, increases with the number of cesareans and high as 67% risk if they've had 4 or more cesareans. We really don't recommend the patient have any more than 3 because it really does set them up for this complication. It does carry a high morbidity and mortality rate if it's discovered at the time of delivery. And if you think about that, you're running into a major problem. You don't have anything ready. The patient isn't prepped. You're rushing to get blood and fluids in the patient because you're in the midst of a major hemorrhage situation. Known risk factors and radiological studies have allowed for diagnosis in the antepartum period. So the good news about this is we are able to detect these more than we used to, just because the advance in technology with ultrasound. And we're probably more likely going to pick up on a per accreta than we are the other 2 disorders. And why is that? Because there's a higher degree of invasion. So when you do an ultrasound, we inspect where the placenta location is. We look at it really closely. We check the blood flow. And the blood flow is going to tell us where that placenta is going. Okay, because think about a malignant tumor. A malignant tumor carries its own blood supply with it. So it will show up when you see it. So the same thing here. So we turn on the color Doppler. It lights up like a Christmas tree because we can see the blood flow going into the bowel or bladder from outside the uterus. Incretas and accretas are a little bit more difficult to detect just because they're not as invasive. But some of these we can see, especially at the placenta previa, because they are kind of going into the cervix a little bit. So we do have to do careful and thoughtful planning when we know we have a procreta. These patients are going to be a hysterectomy. This is the only treatment for a procreta. There's no way to be able to remove that placenta without taking out the uterus. So these patients will need a hysterectomy and oftentimes will need reconstructive surgery of the bowel or bladder. So these are done in the main OR. We don't do them in the labor and delivery OR just because they need a lot of room to be able to work. There's a large team of people there, and it's a pretty lengthy surgery just to take care of these patients. It can lead to significant blood loss, so we know that, and especially if it's undiagnosed. Okay, so this picture is showing you here a normal placenta on the left. You can see the decidual layer there. Okay, this white line is the decidua. That's the membrane that the placenta normally attaches to, and then it comes off and is delivered no problem. This placenta is a little bit low-lying. We call it a low-lying placenta. And generally, if it's measured to be at least 2 centimeters away from the internal os here, then they can safely deliver vaginally. If it's any closer than that, there'll be a cesarean delivery just because the risk of bleeding is too high. Here you see the accreta. Accreta is right into the the endometrial layer. And your myometrium for your increta is showing invasion here, so it's in the muscle layer. And then the procreta, as you can see, is going outside the uterus. Okay, uterine inversion. It's literally that. The uterus turns inside out and is coming out of the vaginal cavity. It does cause significant bleeding, okay, it's because you've got uterine atony, okay? Your uterus is not going to be firm, it's going to be completely atonic with those holes where the placenta was and the uterus exposed. They're not going to contract down. It's going to bleed out, okay, and quickly. It's caused by vigorous massage, fundal implantation of the placenta, excessive traction applied to the cord, short cord, abnormally adherent placenta, and nulliparity. So we know a lot of these are caused by the provider is too impatient to wait for the placenta to deliver, and they put too much traction on the cord and they end up pulling out the whole thing, sometimes with the placenta attached to it. So they need to take a lot of caution to prevent this. But it can also be caused by doing a uterine massage that's too vigorous. So when you do a uterine massage, you want to support the pubic bone, find the fundus, which is going to probably be about at the umbilicus after delivery. You're going to press down and you're going to press down firmly and move your hand in a circular motion on the uterus until it firms up like a softball. You don't want to continually mash on the uterus like you're mashing, like you're kneading bread. You don't need to do that. So just be really careful when you're massaging a uterus that you're not too aggressive. It is an emergency that requires immediate replacement of the uterus in the pelvic cavity. So if you are the nurse at the bedside and your patient's uterus is inverted, you will need to do this. You will need to grab it, put it back in, and hold pressure until help comes. So genital tract lacerations, so the most common are perineal, vulvar, vaginal, and cervical. It is the second leading cause of postpartum hemorrhage. So risk factors include instrumental vaginal delivery, so we're using vacuum or forceps delivery to deliver the baby. Anytime we're putting instrumentation or anything in the patient's body, it runs the risk of causing a tear. Fetal malpresentation, so they may have a very wide head. Sometimes they'll come down with their little hand by the head. It's called a compound presentation, which can lead to more tears. Fetal macrosomia, so the baby's very large, particularly the head. Episiotomy. Episiotomy, it is not recommended for routine use of episiotomies, although there are some providers out there that are still doing this routinely. It is not recommended. It can cause a lot of pelvic floor damage unnecessarily. So it's better to allow the patient to tear and repair that than to make a cut in the patient. There are some cases that episiotomy may be necessary, and shoulder dystocia is one of those, and we'll talk about that when we do the shoulder dystocia lecture. Precipitous birth. The baby tends to shoot out like a dart, and because there's no time for the perineum and structures to stretch, it tears it. Cerclage placement. Cerclages are done early in the pregnancy to prevent pregnancy loss. Generally, cerclages do not cause major hemorrhage, but in the case where the patient may be contracting with a cerclage in place, they can bleed from that. And then last, shoulder dystocia. So shoulder dystocia, again, the shoulder's getting stuck. The uterus is still working really hard to try to deliver the baby, but it can't deliver the baby. So it's causing the uterus to be tired. So what happens is they often bleed after the shoulder dystocia is resolved. Okay, so how do we know it's acne versus genital tract bleeding? So your first clue is you have a firm fundus. If you're massaging the uterus and it's like a softball, like a rock, you're not having uterine acne, so you know that. Also, you're going to continue to see a small trickle of blood coming out. It's like a little stream coming out. Usually the bleeding is much, much more bright red versus clots and dark red bleeding that you'll see with uterine acne. They will bleed despite emptying the bladder. Now, a full bladder gets in the way of the uterus. So the uterus will tend to be lazy if there's a full bladder, which is located right under it, pushing it up, okay? Usually with a full bladder, you're going to find the fundus up and deviated to the right side. Okay, it's going to be way higher than you had expected. So that's how you know you have a full bladder. And if that's the case, you need to try to have the patient void or you need to straight cath them. The patient complains of increasing perineal pain. Okay, what could that mean? Okay, well, hematoma. Okay, we talked a little bit about that earlier. Hematomas are not evident a lot of times, especially if the patient can't see it, you can't see it, it could be high up in the vaginal wall. And sometimes the only way to feel it is if it grows large enough and that you're doing an exam and you can feel it in the wall. It feels like a really hard ball. And so the patient will often complain of severe pain. And it's not normal for a patient to require high doses of pain medication after a vaginal delivery. Okay, so that should be a clue that you need to look down there and see what's going on. The patient often can't walk normal. They can't sit down in a chair. It hurts them too much. So you always want to investigate what's going on. So you want to visually inspect the cervix, vagina, perineum, and labia with evidence of bleeding. And if you can't see it and the provider's gone, they need to come back and evaluate this patient. The cervix is very vascular and can bleed profusely. Hematoma may be evident in the absence of obvious blood loss. And again, this is where you're going to start seeing changes in your vital signs. The patient's going to get tachycardic first. They're going to drop their blood pressure. If they've lost over 1,000 mLs, they're going to start dropping their blood pressure. And once the blood pressure drops, your patient's really hypovolemic. Okay, so you have to remember that too. Okay, so lacerations or perineal tears. So first degree is the most minor. This is injury to the skin and subcutaneous tissue of the perineum and vaginal epithelium. So this is essentially just like a scrape. Sometimes we refer to it as a skid mark. You might hear that. But it's usually a scrape that's usually hemodynamically stable. We can usually put a little bit of pressure on it to stop the bleeding, and they don't require suturing. Occasionally, if it is bleeding, we may need to throw a stitch or two in there. Second degree is more involving of the perineal muscle, fascia, and fibers may extend down a little bit below. So these do need repair. We never want to leave these unrepaired because then it has to heal by secondary intention, and a lot of times these don't really heal correctly. So they do need to be repaired. Third degree extends down to the rectal capsule. It doesn't go through it, but you can actually see a band of white tissue that's horizontal, and then that's how you know you're at the rectal capsule. And then lastly, a fourth degree tear, which is the most severe. These go all the way through the rectal capsule. Okay, we very, very rarely see third or fourth degrees, but they do happen. They require extensive repair. A lot of times they will repair these in the OR, and the reason being is just the lighting is better back there. There's more instruments. A lot of times the surgeon needs help kind of being able to see, and you may be asked to help with that, but these are pretty extensive, so it takes a while to fix these. And we always want to make sure that patient gets put back together right, because with those fourth degrees, if they're not repaired correctly, they can develop a vaginal anal fistula, which is not pretty. Okay, hematomas. So these again result from lacerated blood vessels in the superficial fascia. of the anterior and posterior triangle of the vulva. They may require surgical evacuation if they're large. So large really means if they're greater than 5 centimeters. A lot of these need to be drained and packed. They may extend to the rectal area, caused by multiple small vessel lacerations. We talked about packing. Retroperitoneal hematomas are rare but may occur and can be life-threatening. And this is essentially where they just tear back into their peritoneal cavity and then they just fill up with blood and they're bleeding internally. And then they become hemodynamically unstable quickly. Because if you can imagine somebody bleeding from the femoral artery, this is how these patients tend to exsanguinate. Okay, it's really not any different. It's really scary. We have to recognize it so we can treat it right away. Okay, this is what a labial hematoma looks like. You can see that left side of the labia is much, much larger than the right side. A lot of these patients do get a significant amount of swelling in the perineal area, even before they're pushing. But usually during the process of pushing and this, that, they're going to get a lot of swelling. But your key here is you're looking at the size difference. And this is a pretty large hematoma, so that's probably going to get evacuated. And if you can see at the bottom there, there's some bluish color discoloration. And a lot of times that's one of your clues there's a hematoma. If you can see like a bruise-like or a bluish color, that patient has a hematoma. And it may be small, it may be something you just watch, but look for that and make sure it's not getting bigger. So a treatment, what are we going to do? Well, first you want to make sure you identify the source of the bleeding and that you're watching them for signs of shock. Initiate postpartum hemorrhage protocol, rapid response, safety bundles. A lot of hospitals have these in place. Okay, so CMQCC is a really good resource to go to, that they have a whole a bundle about how to manage it. Anticipate hemorrhage, especially when the patient has risk factors, and this is the best thing we can do. You always want to assume your patient has risk factors just because they're having a baby, okay? A lot of cases of postpartum hemorrhage that I have seen over my career are patients with no risk factors at all, okay? And you never expect it. So you kind of have to always go into the mindset that what if my patient hemorrhages? Okay, so if we do know they have risk factors, that can help us better prepare. Things like having extra IVs, extra IV fluids, having medications, uterotonic medications at the bedside, doing a type and cross match on demand or cross matching for blood. Okay, those are the kind of things we can do. So again, you want to get lab studies, CBC. Every patient that's admitted to labor and delivery gets a CBC. And we're looking at hematocrit and hemoglobin because we want to make sure the patient's not anemic going in. Okay, because that will tell us too, they don't have much blood loss to afford. Okay, because if they have a hemoglobin of 9 before they deliver, we know they're going to drop more. So it can give us an alert to be ready for hemorrhage for this patient. We always get their blood type. We do that early in pregnancy, cross-match coags, anticipate transfusing blood products, okay? And along with that, you want to make sure that you've got a good working IV. Now, we put 18 gauge or 18 gauge or larger in every single patient admitted to labor and delivery. Why? Because we know they're going to bleed. Most of these women have great veins. It's not a problem. If we have to put a 20 in them, we will, but we really try to get 18s minimally, just because we know they're going to lose blood. If you have a patient hemorrhaging, you need a second IV line and you need to be hanging normal saline with blood tubing. Now, because you know you're going to have to hang blood and you cannot hang anything else or give any other medications in that line. Okay, so you have someone hemorrhaging out, you want to get on top of that. Because once they bled out so much too, they're going to be really difficult to get an IV in. Okay, so we need to make sure we're doing that. Administer uterotonics and fundal massage. Now we're going to talk about what those uterotonics are. Alert anesthesia and OR. If your patient is not responding to medications, they're going to go back to labor and delivery and go to surgery. Okay, this is what's going to happen. So we want to make sure that we're alerting the people that we need to. And then we talked about surgical intervention. So they may need a D&C. A lot of times with retained products, that's the case. We may place a Bacri balloon, and we'll talk about that in a minute, uterine packing, or we may not be able to stop it at all, and they may need a hysterectomy. They can go into DIC and end up in ICU admission. I can tell you, if they are in DIC, they are going to go to ICU. So this is your Bacri balloon. Okay, so this has been out probably 15 years-ish. Okay, and this is a tamponade balloon that we put in. So it comes in the package kind of deflated like a big tube. And then what we do is, under ultrasound guidance, we place the balloon in the uterus, because we want to make sure that it's not low in the uterus. We want it nice and up high in the fundus. And so then once we place it, we fill the balloon. It holds about 500-ish mLs of fluid. And then it tamponades or holds pressure where those bleeding vessels were. Okay, so that's essentially what it does. And then there's a little tube at the top with a hole. And that tube collects blood, and it runs in the inside of this tube and out through a Foley bag. Okay, so we can kind of measure what's coming out. But of course, we want to look down below and see what's coming out there too. This usually stays in about 24 hours. We can deflate it a little bit, maybe halfway through, just to see how they do. And if their bleeding is stable, we'll often take it out. But 24 hours is the max because of infection. But these have saved a lot of women a hysterectomy. Okay, the JADA system is a new technology that has just come out. I first heard about this in 2022, so it's been around a couple of years already. It can be placed by anyone trained and easily to place with training. So the great news about this is nurses can place this device, where the Bacri balloon, a provider has to place that. It is more expensive than the Bacri balloon, of course. Usually anything new coming out is going to be expensive. The Pearl study found that success in control of bleeding in 94% of study participants. So they had a very small sample, 106 patients, but out of that, 100 had a 94% success, or 94% there had success rate. That's a very, very good result. So it works by a low-level vacuum support. It naturally contracts the uterus to control bleeding. It works within 3 minutes to control the bleeding. The uterus basically collapses on top of the device, and it's noted within 1 minute of studies. And then it's placed just past the internal os of the cervix, attached to wall suction to remove blood while there's a cervical seal. And it's left in place 30 minutes to an hour, then removed. And they should be stable after that. Okay, so if the patient does have retained products, though, that needs to be investigated because it may not work, or the patient might start bleeding again. So really, the uterus needs to be empty for this to work. And then you observe for further bleeding. So this is what the device looks like. You place it, and the uterus essentially contracts on it, and that's held in place with wall suction. So you want to identify the cause. Again, this is a little table just showing you tone, trauma, tissue, thrombin. Again, 70% of these cases are atonic uterus. Okay, what about medical management? We talked a little bit about this, but fundal massage, and you don't want to be too vigorous, and administration of Pitocin. Again, Pitocin is a first-line treatment. It's gold standard for patients after delivery. Now, Amstel, or active management in the third stage of labor, is utilized after delivery of the newborn. Okay, so what it means is basically we're having the nurse start the Pitocin wide open after delivery of the baby. Some providers will still give the Pitocin after the placenta, and you may see this in clinical. But there's a lot of studies supporting Amstel, and that it's way more effective to utilize that than to to give Pitocin after the placenta because it decreases blood loss by up to 60%. And when I was practicing, I used this practice routinely, and it was very, very effective, and my patients had less blood loss. So again, it's a gold standard. You want to empty the bladder. We talked about how important that is. So even if you think your patient's bladder might be empty, if they're bleeding, they're hemorrhaging, you got to do it. Methergin is the next medication typically that we would use. It's given IM. We just give it right in the thigh. If the patient has preeclampsia or they're hypertensive, you want to avoid it though, because it's going to exacerbate hypertension. Misoprostol, we can do it perirectal or buccal. If you're in a hemorrhage situation where your patient's bleeding out, I would go the buccal route. And you're going to use a less dose. So it's 400 micrograms, and you just put it in the cheek and let it absolve. Okay, let it dissolve in the cheek, and then it can be given. You can actually use up to 1,000 micrograms of misoprostol rectally. I usually would give it if the patient was bleeding a little heavier, not really necessarily a hemorrhage. But if they are bleeding a little heavier or they had a history of hemorrhage, a lot of times I would just prophylactically give them the misoprostol. Now, just be aware that it's common for them to get a fever with the use of misoprostol. And it's usually not a high fever, it's usually a low-grade fever in the 99 range, but just be aware of that. Hemabate IM, it is contraindicated in women with asthma, so you don't want to use that if they have a history of asthma. So again, knowing the patient's history is really important. We tend to kind of reserve Hemabate for last because there are some kind of nasty GI side effects with it, namely the patient gets profuse diarrhea, and so we tend to avoid Hemabate if we can, but again, if they're hemorrhaging, we go through all the medications, we give them everything we can that's possible to give them. Tranexamic acid is also known as TXA, given 1 gram IV, and it works very well in the OB population with very few risks. If the patient does have a risk of clots, we tend to avoid this one, but it does work very well just to help the patient clot. The main thing about TXA is it helps prevent the patient from going into DIC. And you want to give them oxygen by face mask, okay? You want to increase oxygenation, increase fluids, perfusion, all of that. And then bimanual compression may be used to control bleeding until surgical intervention. And so if you work in a rural setting and you had a patient deliver and you don't have a lot of resources, you may need to do this. And so you can see where you're compressing, kind of manually compressing that uterus to be tight, okay? And so that's what you need to do. So surgical intervention, these are kind of like last-ditch effort measures to try to stop the bleeding. Now, before the Bakri, we had to go to a lot of these interventions. So we may need to do a D&C. A B-Lynch suture is a uterine compression suture where we're actually wrapping suture around the uterus to compress it manually. These sutures dissolve, okay, over time once the patient's stable. Uterine tamponade, we talked about balloon or packing. Bilateral uterine artery ligation. So this is a technique used where we just actually clamp the uterine arteries. The uterine arteries are very large. This is the main blood supply feeding the uterus. So by clamping those arteries, we may be able to control the bleeding from the uterus, figure out where it's coming from, repair it, or we may just do it in preparation for hysterectomy. And then, of course, hysterectomy is the last-ditch resort. If we have to save that patient's life, her uterus is coming out. So interventions. You want to be prepared for any woman to experience postpartum hemorrhage. It's really like any other obstetrical emergency because a lot of times it occurs in patients and we don't expect it. You want to get help. Pull the emergency cord. You have a patient bleeding. They call you into the room. They say they're bleeding a lot. You look, there's a puddle of blood under them. You're massaging their fundus. They're not responding. Okay, you don't feel it firming up. Pull the emergency cord. Get people in there to help you. Start delegating tasks. Use Amstel, especially women with risk factors. So that's what we recommend for providers. Monitor vital signs. Initially, you'll see tachycardia. Okay, they get tachycardic because they're trying to conserve their blood pressure because their blood volume's decreasing. Once their blood volume reaches a low level, then you're going to start seeing a decrease in the blood pressure. And then your patient's really in trouble. If you're not able to maintain a blood pressure, your patient is exsanguinated a lot of volume. Okay, and the main thing is you got to get fluids in them. Okay, while you're waiting for blood, if they're exsanguinating blood, you got to hang fluids wide open. If you have to use a pressure bag to get fluids in them, because you want to try to temporarily maintain their volume until you can get that blood there. And I've been in these situations before. It's very scary. Okay, that's why it's imperative that you get help in the room. Start having people do these things. Assess the clinical picture. What are they telling you? Do they tell you they feel bad? Do they feel lightheaded? Do they feel like they're going to pass out? Are they telling you they think they're going to die? Okay, these are all bad things, okay? And you got to pay attention to what they're telling you, okay? Because 9 times out of 10, if they have nausea, dizziness, they feel like they're going to pass out, they have a very low blood pressure. Okay, so just remember that. Assess peri pads for blood loss, and you want to save the pads because you're going to do tare weights and you're going to be weighing saturated things against the dry things. So you can estimate and get a really good, accurate blood loss measurement. If no blood is seen, suspect internal hemorrhage. Okay, so yes, you want to do that. Okay, one other thing I do want to mention is a lot of hospitals will have an emergency box of blood products. Okay, here in Reno we use the red box, and they have the pink box too. So the red box is O negative, uncross-matched blood that we can call the blood bank and get it within 10 minutes if we have a hemorrhage situation. So if we have to give blood quickly, they usually will send us 4 units of packed RBCs, 2 units of FFP or fresh frozen plasma, 2 units of platelets. And all we have to do is call down there and someone can go down there and pick it up, okay? And then we bring it to the bedside. So that's the important thing about knowing if the patient has one of these conditions or they have a risk factor, because we can have that blood ready. But in the case of emergency, we use uncross-match O negative blood. The pink box just has the RBCs. So they have like 4 units of packed RBCs. And that's the key. That's what's going to save your patient's life. So you got to get that volume replaced. Okay, so just keep that in mind. You also want to keep your patient warm. You don't want them to get hypothermic in a hemorrhage situation because that's just going to impede blood flow and oxygenation in their body. Okay, if you guys have any questions, please post them, email me in Canvas. Thank you.